This presentation is on acute bronchitis. Acute bronchitis is a common illness, especially during the cold and flu season, in which viruses such as the common cold, influenza, RSV, or COVID are more prevalent. Bacteria such as Streptococcus pneumoniae causing bronchitis is possible, although uncommon. It is commonly described as a chest cold due to the respiratory symptoms that present, such as a cough, shortness of breath, and mucus production. In the acute state, symptoms typically clear in 2 to 3 weeks. The pathogenesis of acute bronchitis begins with the patient being exposed to an irritant that triggers the reaction. Triggers include viral infections, common cold, influenza, RSV, COVID, allergens such as dust and pet dander, environmental factors, and pollutants such as secondhand smoke, chemical exposure, and air pollution. These irritants cause the bronchi to swell and fill with mucus, trapping irritants. Bronchospasm and coughing is the body's way of expelling the irritants to clear the respiratory tract. Everyone is at risk for bronchitis due to the commonality of the disease. However, some conditions place one at a higher risk for developing bronchitis. This includes having pre-existing respiratory conditions such as COPD or asthma. These conditions leave the respiratory system in an already compromised state. Immunosuppression leads the patient to be at a higher risk of acquiring illness. Smoking or exposure to secondhand smoke is a risk factor as these already cause irritation to the bronchi and damage the lung lining. Allergies, environmental changes, and exposure to pollution lead the patient to exposure of irritants that commonly affect the respiratory system and can cause bronchitis. The most common symptom of bronchitis is a cough. This may be dry and non-productive, and then productive to expel mucus. Sputum is seen to be clear, yellow, or sometimes purulent. It is important to remember that purulent sputum does not necessarily mean that someone needs to be prescribed antibiotics. Patients with acute bronchitis generally feel run down and fatigued. They may complain of sinus congestion due to the mucus buildup, which may create sinus pressure and cause a headache. Chest pain often can occur due to congestion and coughing, but it is vital to investigate this claim further if stated to avoid missing a crucial diagnosis. Fevers may occur due to virus exposure, although this typically does not continue past the first days of illness. If a patient presents with a continued or elevating fever, consider assessing for a pneumonia or an additional diagnosis. Consider a patient's presentation when considering the diagnosis of bronchitis versus a more severe condition. Patients with bronchitis are mildly ill-appearing with potentially a low-grade fever. A common assessment finding is a cough that may be productive or non-productive. Upon listening to lung fields, wheezing or rhonchi may be present, but also may improve with coughing due to mucus clearing. Vital signs may reveal tachycardia, but typically do not show signs of tachypnea, hypoxia, or high-grade fever. Signs of a condition such as pneumonia on examination show a patient moderately to severely ill-appearing, typically with a high-grade fever, showing signs of tachypnea and possibly hypoxia. Lung sounds may reveal signs such as decreased sounds or crackles, and if these findings are present, a provider should further assess for pneumonia or other conditions versus a bronchitis diagnosis. It is crucial to review and consider assessment findings in the patient's history to rule out more serious conditions that would be causing a cough, such as pneumonia, pertussis, tuberculosis, asthma exacerbation, COPD, and heart failure. Suppose a patient is presenting within a normal range of vital signs, they are not hypoxic or showing high-grade fever, and assessment findings show no immediate concerns. Then, based on assessment findings and symptoms, a provider may diagnose bronchitis. If further conditions are still in question, testing can be done to rule out a differential diagnosis. A chest x-ray is typically within normal findings with bronchitis, although it may demonstrate bronchial wall thickening. However, infiltrates or consolidations would be shown in a chest x-ray of a patient with pneumonia. The American College of Chest Physicians recommend only obtaining a chest x-ray when signs of infection are present, such as lung sounds consistent with pneumonia, tachycardia, tachypnea greater than 24 breaths per minute, and a fever more significant than 38 degrees Celsius or 100.4 degrees Fahrenheit. A CBC can be drawn to review signs of infection such as increased presence of white blood cells. Cultures such as influenza, pertussis, or coronavirus testing may be considered for treatment plans. Although pulmonary function testing is typically not affected by bronchitis, it should be considered if asthma or COPD is suspected. It is seen that there is little benefit of antibiotic usage in the case of bronchitis. Antibiotics are seen to have minor effects on the length of symptoms and length of illness. They are commonly prescribed, although the risks outweigh the benefits. Patients still experience side effects of these medications and leads the patient to an increased risk of antibiotic resistance in conditions such as C. diff. Although not necessary, some medications can be prescribed or recommended for symptom management. Antitussives such as benzonatate or Tessalon pearls, 100 to 200 milligrams 3 times a day as needed, can assist in managing or relieving a cough. There is maximum dosage of 600 milligrams daily of benzonatate. Analgesics such as acetaminophen or ibuprofen may be recommended for pain or fever management, although reminding patients not to exceed 4,000 milligrams of acetaminophen in 24 hours is essential. Short-acting bronchodilators such as albuterol may be prescribed if the patient is presenting with wheezing. This would be prescribed as 2 puffs every 4 to 6 hours as needed. Decongestants and antihistamines are determined ineffective unless a known allergen is the causative agent of bronchitis. The patient should be educated on non-pharmacological methods to manage illness and symptoms. Most importantly, the patient should take this time to rest and allow their body to recover. Increasing their fluid intake will assist in preventing dehydration and also help in the thinning of mucus. Warm beverages such as tea, throat lozenges, saline nasal spray, and honey may help clear sinuses, relieve throat pain, and diminish cough. However, it is crucial to educate on the avoidance of honey in children younger than 1 year old. Education is necessary to assist patients in preventing and treating illness. Acute bronchitis occurs due to causative agents or triggers that cause inflammation in the airways. Therefore, avoiding these triggers and allergens decreases the risk of bronchitis occurring. Although it is difficult to avoid all viruses we may come in contact with, using methods such as good hand hygiene and staying updated on vaccinations decreases the spread of illness. Patients should also be notified to follow up with a provider if their symptoms worsen or are not improving, and they should seek emergency care if they are having difficulty breathing.